um, thank you. So we're recording. If anybody doesn't want to be visible, take your visual off or take your name off. Carolyn, I did forget to ask you if you were okay with being recorded, but
that's fine. That's fine.
Okay, so welcome all, and I'm going to turn it over to Carolyn Lentzsch Parcells.
Thank you. Let me get my screen up here for y'all. And then I'll kind of introduce myself a little bit. Hang on. Come on now. Play slideshow. Oh, come on now. Of course, it decides to be persnickety at the moment. Here we go. Okay, there it is. Okay, so we are going to be talking about medications for the treatment of ADHD. As she said, I'm Dr. Carolyn Lentzsch Parcells. I'm a board certified pediatrician with Girls to Women and Young Men's Health and Wellness in Fort Worth, Texas. I practice what's called adolescent medicine. So I primarily take care of folks ages about 10 to about 25. I say about because I do see kids as young as 6, particularly for things like ADHD. And I see them kind of as soon as they're ready to grow up and fly away from me. And for some folks, that's before 25. And for some of them, that is after 25. So I see kind of a wide range of kids there. A large part of my practice is taking care of children and teens and young adults with ADHD. But I also myself have ADHD, and I also have a learning disability. So this community, this work, educating our community on these topics is very, very near and dear to my heart. And I think it also gives me a pretty unique perspective because while I obviously understand this stuff as a physician, I also very much understand from the adult human who has ADHD standpoint, even from the standpoint of how hard it can be to find somebody to write and prescribe your medications, or how hard it can be to get your medications or find the right medication regimen or overall treatment regimen in general, whether that includes medication or not. So that's kind of the perspective that I'm coming from with it. And I am going to try to shove a whole bunch of information into a fairly short period of time because, again, I have ADHD too. So I want to kind of jump right into it. I'm going to try to go at a pretty decent clip so we can get through everything and still have time for questions. If you'll just put your questions in the comment section, we'll get to them at the end. I'm going to try not to go too fast, but we'll see. We'll see.
So Carolyn, I'm going to interrupt you for 1 second. Sure. We'd love to get a copy of your slides so we can post it on our website so people can review it and hear it and look at it again. The recording will also be on our website. So just wanted to thank you.
Fabulous. Okay. So this is kind of, we always like to put up objectives and stuff. And this is kind of the objectives I set for this talk. But really, in reality, what it comes down to is what I hope is that regardless of what perspective you're coming to this talk from, whether you have ADHD, you're a parent, a coach, a teacher, a provider, all of the above, some of the above, my hope is that you'll come away from this talk with a little bit more information, a little bit more comfort level with the medications we use for ADHD, excuse me, and a little bit more information to be able to advocate for yourself or your kids or whoever it is in your life that you love who has ADHD, okay? So first of all, before we jump into the actual medications themselves, I first want to kind of say, okay, well, why are we even having this conversation? Why do we use medications for the treatment of ADHD? And in particular, the medications we're going to talk about tonight, which are the stimulant medications, but also some of the other medications that have come down the pike. Well, the reason we do include medication as part of an overall treatment plan for ADHD is research, right? We have reams and reams of research now that shows that optimal treatment of our ADHD, which isn't just medication, but often does include that, provides better outcomes for ADHD. We've also been, for a lot of these medicines, the stimulant medications in particular, those medications, while we have a lot of new formulations, and we're going to kind of talk about that, these are not new medications. These medications have been around since the 1930s and 40s. Okay, so ADHD is not new. These medications are not new. Okay, now, excuse me, I'm getting over something, so I apologize. So optimal treatment of our ADHD. Okay, the research shows us decreases rates of depression, anxiety, substance abuse, school failure, relationship failure, work failure, accidents, improves social development and relationships. And we now have research from Dr. Russell Barkley, who's one of the kind of lead researchers in our field, that suggests that treating our ADHD may actually also be critical for our physical health and may actually extend our lifespan. What does that mean? Well, his research showed that folks with ADHD whose ADHD is not optimally managed have an average decreased life expectancy of 13 years. Okay, that sounds scary. What it really came down to, though, was that basically when we treat our ADHD and we manage it well, we do a better job of taking care of ourselves overall. We do a better job of initiating and maintaining healthy lifestyle choices like exercise, eating well, those kinds of things. We're more likely to keep up with our wellness visits. We're more likely to keep up with our doctor's visits or medications that may be associated with other things like high blood pressure or diabetes or those kinds of things. The other big thing, though, that comes into play with this, and this is one of the we're talking about averages. So part of why that number is as big as it is because you have to take into consideration the folks that unfortunately lose their lives very young or younger than they should have due to things like accidents or even suicide. So that's part of what pulls that number down. So the overall point of that is not to bum you out, but to say that treating our ADHD is actually incredibly important for our overall health and well-being. Okay. So as I said, ADHD is not new. These medications, or at least a lot of them, are not new, but we are still learning. We're still learning about ADHD, and we are still learning things about these medications and how they work and how best to use them. What we do know so far is that the medications that we've been using for the most part as our first line medications in ADHD typically target two of the neurotransmitters that are the most or the ones that we know, I should say, are an issue in ADHD: dopamine and norepinephrine. Excuse me. Those, while all of the neurotransmitters probably play a little bit of a role, dopamine and norepinephrine are the two that seem to play probably the most significant role in ADHD. So what neurotransmitters are, if you don't know, is they're chemicals in the brain that our brain cells make to send signals from one brain cell to another. Okay. If those neurotransmitters are not produced enough or aren't utilized properly or are degraded or broken down and recycled, taken out of the system too soon, they don't work as well. Dopamine and norepinephrine in particular affect things like attention and alertness and motivation. You can see how these are kind of an issue in ADHD. What the medications that we're going to talk about target or try to do is essentially increasing the available dopamine or norepinephrine in the brain so that the brain cells can communicate better and function better. Now, that is not to say that medication is a magic bullet or the end all be all or a cure, but I actually get really up on my soapbox when people talk about medication being or not being a cure, because we do not need a cure. I hope a lot of you would agree with me that while ADHD absolutely has its challenges, and while we need to face those challenges and manage those challenges, hence why we're having a conversation about medication, ADHD also has its gifts. And so, whoopsies, my slides are not responding. Oh, there we go. Okay, there we go. So when I bring this up in the conversation of medications, because when we're talking about why we use medications and what to expect from them, one of the things that I think is really important is to acknowledge the gifts that we have from ADHD and the fact that these are not things that we want to get rid of or have them go away because of medication. So things like creativity, passion and enthusiasm, attention to detail. I put sometimes here because it actually bothers me when people talk about the fact that we miss details and leave it at that. Because yes, we do often miss details that maybe we were supposed to notice or that other people think we're supposed to notice, but we also have a tendency to see the details that other people miss. And I personally think that is a huge gift because that's one of the things that I think make me good at what I do, because that's part of what makes me a good diagnostician, is catching those little details that other people might have missed. We can be excellent problem solvers, especially because we often see solutions to problems that other people don't see, or we approach a problem in a different way. We're often very entrepreneurial, which in and of itself means taking risks, right? We always talk about risk taking in a very negative way, I think, especially when we're talking about like young adults and teenagers. And I'm not saying there's not some risk taking that's maybe not the best choice, but overall, being willing to take risks in and of itself is not always a negative thing. So I always tell people pills don't build skills, but they sure as heck help us use them, right? We still have to learn we still have to build skills. We still have to learn how to do things differently because our brains work differently. And pills don't do that for us. However, ideally, if we have the right medication that's working well for us, what the medication does help us do is, one, pay attention and focus well enough to be able to actually attend and learn that skill and store it properly in our brain so we can recall it at a later time. But then in addition to that, it gives us that, what I like to call frontal lobe speed bump, to go in a moment to be like, hold up, wait, how do I want to do this? What do I want to do? Oh, right. Pull that skill forward and use it. Because how many times have we been sitting there and something has happened or a situation has occurred and we know the skill or we know the strategy, we've practiced it, and we still didn't use it in the moment? Thanks, impulse control. One of Dr. Barkley's quotes that I actually really love is he said, ADHD is not a disorder of knowing what to do. It's a disorder of doing what we know, which I think is excellent. And I think the medication, again, if we've got the right one for us, helps us to do just that. So whoopsie doodle, sorry about that, guys. One of my ADHD coping strategies is I set an incredible number of alarms to make sure everything stays on track. So one of the ways I kind of describe medication and what our expectation should be and how we want to be using medication is I use a superhero analogy. And I know that not everybody in our community is a huge fan of the superhero analogy, but if you're one of those folks, stick with me here for a minute, because I feel like I do mine a little bit differently. And it's actually something I came up with one of my sweet little patients in the room when we were trying to kind of discuss medications. So the way I describe it is that if you think of any superhero's origin story, right, which is big right now, pretty much every superhero at some point in time, their superpower was thought to be dangerous or evil or scary or out of control, either by themselves, by society, by those around them, some combination thereof. Some superheroes just have to learn how to control their power and use it for good, not evil. But some of them need equipment. I love using Cyclops here for this analogy. Cyclops is one of the X-Men who has laser beams flying out his eyeballs all the time. He can't control it. There's nothing he can do about it. That seems like a pretty negative and destructive superpower in and of itself. But he has his visor. He needs his visor. His visor, though, I think this is one of the really key points. His visor does not eliminate the laser beams. It does not take away the laser beams. It gives him the control over when he uses them and when he doesn't. So just like Cyclops and his visor, the medication should not take away any of those positive aspects of our ADHD or who we are, or make us feel like a different person in any way, shape, or form. Ideally, what the medication should do is give us the control over how and when we use those gifts. It should give us the control over the ADHD as opposed to the ADHD having control over us. And that's how I like to describe kind of the expectation of what we're looking for when we're working on the medications. So, and jump down off that soapbox now for a hot minute, and let's get into the actual medications. We're going to start first with the stimulant medications. The stimulant medications are still the first line, gold standard medications for ADHD. And they are so because that's what the research shows us. We still have not found a medication that can fully stand up to the stimulants, at least from the research, as to being as effective as a solo agent or by itself. So what can stimulants help with? Well, they can, and I say can because everybody's different. But the stimulant medications can help with attention, focus, staying on task, motivation, organization, impulsivity, hyperactivity, emotional regulation, et cetera, et cetera. So basically the stimulant medications can, at least in theory, help with all of the core symptoms of ADHD, as well as help with our overall functioning, again, for the right person in the right scenario. Common side effects that are possible amongst all of the stimulants. These are just common side effects. This is not an exhaustive list, please, okay? But the most common things that we see: headache, stomachache, decreased appetite, weight loss, trouble sleeping, increased irritability, anxiety, restlessness, kind of just feeling like revved up in not a very fun way, or the opposite, feeling blunted out, blah, zombified, not your usual fabulous self, as I like to tell my patients. We could also see worsening mood as opposed to improving mood. I find dry mouth tends to be more of a side effect that we see more in adult patients, but we certainly can see it in younger ones. I included tics on here actually because I think it's a point that needs to be made. It's not actually a side effect of stimulants. It's more that for somebody who already has tics or has a brain that is predisposed to tic, the stimulant medications can uncover that or can worsen it. But that's a little bit different than it actually causing tics. That's a little subtle difference there. Now, what's really fascinating though about the side effects is while these are potential side effects across the board with all stimulants, I've been doing this for a very long time, and it is fascinating to me how even within the same family, and we're going to talk about the different families of stimulants, but even within, say, 2 or 3 formulations of, say, methylphenidate in the same person, you can respond completely differently. So if you have side effects to one, doesn't mean you're going to have side effects to all of them. You might, but you might not. And same with the efficacy too. And I think that's a really important point to make. So a lot of my patients come to me and they've tried 1 or 2 stimulants, maybe even only at 1 or 2 doses. And because of the side effects they had, or the fact that they didn't feel like they worked very well, they stopped trying, when there's this huge long list of all these medications they could have tried that they might have responded differently to. So that's the main point I like to make about that. So with all the stimulants across the board, the dosing is really interesting, actually. And I want to be really clear about this. It is not based on age, weight, size, severity of illness. Okay. I have little tiny munchkins who are on doses of stimulants that would make your eyes pop out. And I have older folks who are on what seem like almost homeopathic doses of stimulant medication. It's about your brain, your body, how your liver, how your body processes these medications, how your body reacts to these medications. So for everyone across the board, we start at the lowest or one of the lowest doses, and we titrate or work our way up stepwise until we reach the most effective dose that is the best tolerated, preferably without any side effects, but at least with the least and most tolerable side effects. And that's how we do and should do all of these medications for all ages. Okay. So within the stimulants, I mentioned that there's 2 families. So there's 2 families of medications in the stimulants. There's the methylphenidates, and then there's the amphetamines. The methylphenidates are things like names you might have heard, are things like Concerta, Ritalin, generic methylphenidate, Metadate. There's now some other fancier ones in there. The amphetamines are things like Adderall, Vyvanse, Dynavel. Again, we've got some other new fancy ones in there. Okay, and we're going to talk about the differences between the 2. So we're going to start with the methylphenidates. Okay, the mechanism of action, or the way they work, is that they increase available dopamine in the brain. Remember, we talked about that dopamine earlier, by inhibiting dopamine reuptake by the neurons. What does that mean? Well, when one brain cell makes the dopamine, spurts it out, right, in between the space between the neurons, uses it to communicate, then it gets taken back up by the cell and recycled, basically degraded and gotten rid of. What methylphenidate does is it blocks that receptor. It keeps the methylphenidate the dopamine from being taken up and taken out of the system, so that you can use that dopamine for longer and therefore kind of increasing the level of dopamine in the brain in that way. So your brain's not making more dopamine. You're just using what you have better, at least in theory. What's really fascinating about this class of medication is, aside from Focalin, and I'll come back to that one in a minute, every single methylphenidate, all the different formulations are all the same molecule. That's it. Same molecule. It's all methylphenidate. The only difference is the formulation, but it's absolutely mind-blowing, as I kind of mentioned earlier, how much difference the formulation can make for a single individual as to not only what side effects are caused, but also how efficacious the medication is. And we'll get into a little bit more of those details in a second. So how do the different formulations differ? Okay. The big thing is how the medication is released and when, like how much at what times, and also kind of how long it lasts. And we'll get into that in a minute. So first of all, there's within those methylphenidates, there's the short acting or immediate release formulations, and there's long acting or extended release formulations. We're going to start with the short acting. The short acting, I put some of the trade names up there: Focalin, Ritalin, Methylin, methylphenidate. But usually most people, when they're using it, you just get methylphenidate generic. Okay. And one of the big differences between just from when you're reading the bottles is if you have methylphenidate on the bottle and there's no other letters after it, like C, D, L, A, or ER, it's the short acting. If you have other letters after it, it might be one of the long acting. Just a little tidbit. So with these medications, they take about 30 minutes to start working, and they last on average about 3 to 5 hours. Good God, I have a lot of these set today. Excuse me. By the way, those are alarms are how I keep my kids on track and get everybody to bed on time. That's why those keep going off. So back to the immediate release. I'm sorry, just a minute. Yes, hon? What do you need? That's a daddy question. Okay, yes. Yes. Thank you. Sorry about that, guys. So with the immediate release formulations, on average, they last about 3 to 5 hours, but that can vary by person. And I'm going to come back to that in just a minute. In general, because these are so short acting, we actually prefer not to use them as solo agent or the primary medication for most people with ADHD, because if we did, we'd have to dose them 2 to 3 times a day. We're not going to remember to take it 2 to 3 times a day. I'm not going to remember to take it 2 to 3 times a day. So not only is that just really difficult for us to do, but it's also just not as effective for a lot of people. Now, we do have some folks for whom they do tolerate the immediate release better. And so if that's just what works for them, then of course we're going to use that. But that's not our first go-to. Primarily how we tend to use the short acting medications is going to be more of like a booster dose in the afternoon or evening for somebody whose primary long acting medication isn't getting them all the way through the day or through the period of time that they need, or other ways of kind of helping people adjust the timing that they need their medication for. Formulation wise, these come in tabs, chewable, and liquid, which is really nice because we have a variety there. So one of the things I want to come back to is I said on average that these medications last about 3 to 5 hours. And the reason I said on average is because, again, one of the really tricky things about these medications that's different from a lot of other medication classes is these medications can vary extensively in how long they last based on an individual person's metabolism. And when I say metabolism, I mean how your liver clears these and processes these medications. It has nothing to do with food metabolism. Okay. So if somebody is a slow metabolizer, for that person, the medication is going to last longer than expected. If somebody's a fast metabolizer, it's going to last shorter than expected. So for example, I actually do have some kids who are wicked slow metabolizers, and we actually do use the immediate release formulation for their primary medication because it lasts them 8 hours. And the extended release lasts them so long they don't go to sleep. So it depends on the person, but that's actually a really key factor in trying to fine tune and figure out the right regimen for people. The other thing I want to point out about the immediate release formulations is cost is actually a big positive to these because they are generic, because they have been around for so long, because they're not very fancy. The costs, they're very, very affordable. So that is another situation where we may use this as a primary medication, is frankly, if that's what's available and if that's what somebody can comfortably afford, then yeah, we're going to use what they need us to use. One of the biggest downsides, other than just, having to remember to take it multiple times a day, one of the other big downsides of the immediate release formulations, and this is actually both for the methylphenidates and the amphetamines, is the immediate release ones are the ones that are at highest risk for misuse or diversion. Diversion meaning the medication going to people to whom it was not prescribed, especially people who don't have ADHD, but really it just means going to somebody to whom it wasn't prescribed. And it can be misused, particularly in the short-acting formulations. So this is another reason why sometimes people prefer to, if not avoid these medications, at least limit their usage. So the long-acting methylphenidates, I did put all of the trade names on here. I do not have any disclosures. I do not get paid by any pharmaceutical companies, but I did want you to have some idea as to the actual trade names that you might see out there or that might be mentioned to you. Concerta, of course, is one of the oldies but goodies that a lot of people are aware of. Some of the newer versions, Cotempla is a nice little dissolvable. There's Quillavant is a liquid. Now, who decided to have a banana flavored liquid for ADHD kids? I don't know, but probably somebody who does not have ADHD kids. I'm just going to throw that out there. And then Jornay PM is one of the newer ones that I'm actually going to highlight. So I'm going to highlight a few of these, not all of them, just for time's sake, but I'm going to highlight a few that either you are most likely to come in contact with or have kind of some unique features. But in general, for the long-acting methylphenidates, like I said, these are kind of preferred first-line medications. The dosing is typically once a day in the morning. I always tell my patients until they know how long it lasts for them and how it works for them, to start with taking it before 10 a.m., just so they don't take it too late and they're up too late at night. Onset of action, meaning when it starts working, it's anywhere from 20 to 60 minutes, which seems like quite a spread. But again, this can be very individual dependent, but it can also depend on your breakfast. If you have a high protein, high fat breakfast, it's going to take a little bit longer for the medicine to really kick in. Okay. Duration of action, again, is going to last anywhere from 8 to 12 hours. That depends on both the formulation and the person. We do have some formulations that are now lasting or claiming to last up to 14 hours. So, and I'm going to touch on that a little bit. Excuse me. Okay, now we're going to get my slides to work here. Uh-oh, we're having a little glitch. Okay, oop, hold on. There we go. Okay, here we go. So, one of the additional side effects that we have to watch for in the long-acting medications, and this is sometimes a reason why we use a short-acting, is for some people, when they're coming off the long-acting or it's wearing off in the late afternoon, early evening, they can have about an hour to 2 hours of what we call emotional lability. So basically being more emotional, whether that's tearful, irritable, more angry, and that's unique to the long-acting formulations. That's not something we see in the short-acting formulations. For some people, it's mild, barely noticeable. For some people, they don't get it at all. For some people, it's significant enough that it's a real problem and a reason to change the medication. This is actually one of those scenarios though where sometimes we will use that booster dose, because sometimes when we use a booster dose and we overlap it such that the booster starts before those symptoms, we can kind of ease folks off of the long acting a little bit better and really help those symptoms. Just depends on the person though. So the ones that I want to highlight in this class, Concerta, I want to mention both because it is probably one of the most commonly used ones in this class, but also because it's a unique delivery system. So it's what we call an osmotic release that mimics kind of taking that immediate release 3 times a day. But it's smoother than that. It does kind of have a peak and a trough throughout the day, but it's smoother than what we see in some of the other long-acting preparations. It typically lasts about 12 hours, again, for the average metabolizer. But one of the big things that I kind of like to point out with this one is this is one of those situations where not all generics are created equal, okay? The name brand Concerta and at least one of the generics look the same. I tell people they look like a Tic Tac, okay? If it looks like a Tic Tac, that's the osmotic release system. If it looks like a circle, it is not the osmotic release system, okay? And this is one where either one of those could say methylphenidate ER on your bottle. Okay. Now there are folks out there who will tell you that you shouldn't take the circle one at all, blah, 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 blah. It should only be the Tic Tac one. I appreciate their point, but if it works for you, it works for you. And if it's covered for your if the circle one's covered by your insurance and it works, and the Tic Tac's not covered by your insurance, or it doesn't work for you, then okay, cool. But I do think it's important to know because, for example, I've had patients where they started with the Tic Tac one, worked really well for them. They go in, they get a different generic, it's the circle one. It's not working as well for them, or it's not lasting as long for them. Okay. For folks for whom that is the circumstance, okay, well, then the prescribing provider can specify on the script either name brand necessary, or they can specify the particular generic to help avoid that problem. So that's one of the reasons why that one's important to be aware of. Jornay PM. This one's fascinating. I'll be perfectly honest with you. And again, no, I am not paid by them. This is a brand new, well, it's been around for a couple of years now, but it's a new delivery system that we haven't seen previously. It's what we call a delayed extended release. So it's still methylphenidate, but you actually take it at night. And it delays release for 10 hours. It releases less than 5% of the medication through the night, which for most people is not sufficient to affect their sleep in a negative way. And frankly, for some people, it actually helps. And it kicks in automatically on its own first thing in the morning. I don't know about you guys in your house in the morning, but for my ADHD house in the morning, it's challenging. So for example, in theory, if you take it at 8:30 at night, it will start kicking in on its own at 6:30 in the morning. So not only is that really helpful for morning routines, but also for folks who maybe are really sensitive to the GI symptoms, right? The upset stomach or things like that. This doesn't cause quite as much of that, which can be really nice. The other thing about it is, at least for average metabolizers, it's supposed to last about 14 hours. So it kicks in at 6:30 and it would last till 8:30. I do see with my fast metabolizers, certainly it doesn't last them as long, but I don't see quite as much variation with this one as I do with some of the other ones. I also feel like I see less decreased appetite and less weight loss, basically less side effects in general, which is really interesting to me. And it actually makes sense if you look at the kind of fancy what we call pharmacodynamics and pharmacokinetics of it, it actually makes sense. But it's really interesting in that way. So in a lot of ways, this is kind of the closest we've gotten to full day coverage with a stimulant medication. Now, of course, again, it doesn't work for everybody. It's not tolerable for everybody, but it can be a really, really good option for some folks. The other thing I like about it is while it comes in a capsule, it can be sprinkled. So if you have somebody who can't swallow pills or doesn't want to swallow pills, they can still take this, okay? The biggest downside to this one right now, honestly, is accessibility and cost. It is not well covered by insurance companies. It's kind of one of those ones that you need a prior auth, typically need to have failed 2 or 3 formulary medications to get it covered, but they do have an excellent coupon program, which can make it more accessible. Okay. Daytrana. I'll be honest, I'm probably about to pull this slide from my set because really we're not using Daytrana a ton anymore. And it's not because it's not a great medicine. It's a patch. Okay. And again, what's nice about that is you can put it on early in the morning. It can last throughout the day. It can be really helpful for my folks who are fast metabolizers or have a lot of the tummy troubles with the other medications. But the reason I'm probably not going to talk about it too much anymore is because frankly, it's not terribly available anymore. It's not terribly well covered, but it's still kind of a good one to know about, especially if you do struggle with using the kind of traditional medications, the traditional swallow medications. Last but not least, I told you I'd come back to Focalin, and I am. So Focalin, what makes Focalin unique is that it's what we call dexmethylphenidate. So remember how I said all the other formulations were all the same molecule. They were all methylphenidate. Well, what that really means is there's actually 2 mirror image molecules in mixture together, the dexmethylphenidate or the right-handed molecule and the levomethylphenidate or the left-handed molecule. In Focalin, they took the left-handed one out and they just left the right-handed one. The theory was that this was the one that did all the good stuff and this is the one that did all the side effects. Great in theory, not so much in reality. For some people, that is the case though. For some people, this is more effective for them than just the straight up methylphenidate and or better tolerated. That's certainly not the case for everybody. I do have some folks for whom the Focalin is less effective or less tolerated. I personally tend to, and this is not research based, this is Dr. Parcells' personal experience based, but I do feel like this one, I tend to see a little bit higher risk for things like irritability, agitation, anxiety, things like that. So in my folks who kind of are already starting with that symptom set, it doesn't mean I won't try it, but it's not going to be my first go-to. Now, I certainly still have patients who have anxiety who take Focalin and do great with it, but it's just not my first go-to for those folks. Average duration, again, is about 10 to 12 hours. And again, it can be sprinkled. So that's a nice option as well. I put this up here just because, you know, there's a lot of folks who either can't swallow pills or don't want to swallow pills. And we, thank God, have a lot of options for those folks now. We've got chewables, we've got liquids, we've got oral dissolvable, we've got caplets that can be broken open and sprinkled. We got all kinds of stuff. And we have things that are shorter acting and we have things that are longer acting. So I just want to kind of point that out. So moving on to the amphetamine class. That was our methylphenidate friends. We're now moving on to our amphetamine friends. So for the amphetamine class of medications, again, they increase available dopamine in the brain, but these medications do so by increasing the release of dopamine from the neurons. So these medications actually get the brain to pump out more dopamine, okay? So with these, the difference between the formulations, again, similar to the methylphenidates, a lot of it has to do with the difference in the formulation. But with these, not only is a difference in how much medicine is released and when, but there's also a difference between the percentage of dexamphetamine to levoamphetamine. So like I was talking about with the Focalin, with the dex and the levo, in the amphetamine preparations, there's varying amounts of the dexamphetamine, and that can have a difference as to how one medicine might work for somebody versus another. The other thing that I point out with the amphetamines, again, same potential side effects as the methylphenidates, and this does not hold for everybody, but statistically speaking, in general, these medications can have a slightly increased risk for decreased appetite, weight loss, and irritability, especially in the littles. The younger the child is, the more likely they're going to have side effects with the amphetamines. So we actually don't recommend starting amphetamines as first line in the younger school age children. Again, that does not mean that there aren't littles who are on amphetamines and rocking it out. I've got a 9 and 10-year-old sisters who the methylphenidates did not work for them. They're rocking it on some amphetamine preparations and they're tolerating it great. But it's just kind of one of those things that we take into consideration when we're trying to figure out where to start for a particular individual. Okay. So again, we've got the immediate release and the long acting or extended release. For the short acting, we have good old Adderall or generic amphetamine. It often says mixed amphetamine salts is how it looks on the bottle. A Vikio ODT, Procentra, and Zenzetti. Again, usually with the boosters, we're using just kind of the good old Adderall. The formulations, again, come in tabs, chewable, dissolvable, and liquid. Onset, similar to the methylphenidates. It's about 30 minutes till these start kicking in. And the research says they last about 4 to 8 hours, which makes it seem like they last longer than the methylphenidates. In practice, I don't really see that. They're pretty similar to the methylphenidates for most people. Excuse me. And again, similar to how we use the immediate release methylphenidates, we tend to prefer to use these as booster doses as opposed to solo agent. If we're using it as a solo, it's got to be dosed at least 2, sometimes 3 times a day. Excuse me. And again, actually, let me pop back here a little bit. Of note, and I'll kind of circle back around to this a little bit and discuss it a little bit more later. The short-acting Adderall or short-acting amphetamine is unfortunately the one with the greatest risk of diversion and misuse. It's the one with the greatest street value. So that is one that we try to be particularly careful with just because of that. So long-acting or extended release. Here's your long list of fabulousness. I feel like they're adding new ones every day. We're going to highlight a couple of these. Adderall XR is kind of, your oldie but goodie. That's one of the ones that a lot of folks are using these days. The Dynavel is a liquid. The Adzenys is really nice because it's a dissolvable or a liquid. So again, for those folks who can't swallow pills. And there's some There's some data or research to suggest that Adzenys and Dynavel are tolerated a little bit better by the younger ones if they need to be on an amphetamine, but that's not a hard and fast rule. Mydayis is interesting because it is the longest acting in this class other than Vyvanse. It's supposed to last about 14 to 16 hours on average. So again, in general, like I said, they vary by percentage of dexamphetamine and by delivery system. Overall, these medications, again, similar to your methylphenidates, are going to take about 20 to 60 minutes to kick in, also dependent on your breakfast. Last about 8 to 12 hours, except for the Mydayis, like I said, which can last up to 16 hours. One of the main things to know about these is, again, with the long-acting version, you can have that same emotional lability when they're wearing off that we can see with the methylphenidates. Adderall XR, like I said, oldie but goodie, average is about 8 to 12 hours is how long it typically lasts. The percentage of dexamphetamine is about 75%. And that is what you're going to see in pretty much most of those formulations I showed you, other than Avikio, which is a 50-50 formulation, and then Vyvanse, which is completely dexamphetamine, which we'll talk about in a minute. Again, comes in a generic, which makes it a little bit more available, a little bit more affordable, and it approximates twice daily dosing. So it kind of has a wave like this, if you were to look at kind of how the medication is released in the system. Okay. So Vyvanse is really interesting. It's lisdexamphetamine. So a couple things. One, it is just the dexamphetamine, kind of similar to how the Focalin was just dexmethylphenidate. But the Liz is what makes it even more interesting. That's what makes this what we call a prodrug. So in order to be absorbed by the body and actually used as an active drug, the Liz portion that's been tacked on there has to be cleaved by a particular enzyme in order to make the medication active. Okay, great. Why does this matter? Well, it does kind of help with metabolism and kind of make it last a little bit longer, but more importantly, it decreases the risk of misuse. It makes it harder to abuse this medication. It makes it harder to overdose on this medication. So that was kind of the big thing when this came out. Everybody was so excited about it because everybody was so afraid of the misuse and diversion of these medications. And then that's like I said, I think that's kind of what the marketing really pushed and made this medication seem more comfortable for a lot of the doctors out there. Couple of issues with it: cost, for sure. Although it goes generic, I think it's either end of this year or next year is when it finally goes generic. Yay! So that'll make the cost go down and make it more accessible. One of the big issues with Vyvanse, though, is that I do see increased risk of decreased appetite, weight loss, irritability, and anxiety and agitation in comparison to the other medications. It is a fantastic medication for the right person. It's incredibly effective, but the side effects can be rough, especially for the wrong person, and especially for littles. The younger the child, the more likely we are to see those side effects or to see things like skin picking, hair pulling, things like that. So just something to kind of be aware of with that one. Okay, so that was our stimulant medications. The other medications that we use for ADHD fall into what we call non-stimulant medications. The primary group of non-stimulant medications that we have been using and have really been gaining traction, and we're actually really excited about, are the alpha-2 adrenergic agonists. Okay, it's a really fancy name for old school blood pressure medicine. Okay, what's really interesting about these medications is when you look it up, it says that we don't really understand the mechanism of action or how it helps in ADHD. However, what we do know about these medications is that they stimulate inhibitory neurons that decrease sympathetic outflow, which is a gobbledygook way of saying they're chill pills. They literally decrease or tamp down the sympathetic nervous system, also known as our fight or flight system. Okay. Now, what do they do for folks with ADHD? Well, they help with hyperactivity, impulsivity, irritability, aggression, sleep, emotional dysregulation. And we're now finding also rejection sensitivity can be helped by this. Seems like it makes sense to me. as to why this would help with those things, right? But they can be really helpful. And they also have a pretty low side effect profile, which I'll get to in just a second. The medications in this class are guanfacine. The generic terms are guanfacine and clonidine. The long-acting guanfacine is going to be guanfacine ER is the generic, or Intuniv is the trade name. That's the one that most people probably heard of. And clonidine, the trade name for the extended release, is Capvay. These medications are once daily dosing, typically in the morning, so that we get the most benefit throughout the day. However, they can be dosed in the afternoon or evening if they're causing too much sleepiness during the day. Onset, the research says 2 to 3 weeks to take full effect, but I'll tell you right now, you start seeing something pretty fast, like within a couple of days. But as far as the max effect, it can take some time. Duration lasts about 12 to 24 hours, which is great because these are medications as a result that can sometimes kind of help fill the gap where you may not be getting everything you need from a stimulant, but you can't push the stimulant any further or you're not going to get to sleep, right? This can be a really great adjunct to stimulants for that reason. So to that point, part of how we use these medications, we don't typically use them as a solo agent, although they can be in the right person, but they can be really wonderful adjunct with the stimulants because they can help, like I said, fill the gaps, both from symptom control standpoint, but also from a timing standpoint. They can also help for folks who either can't tolerate a stimulant or can't tolerate getting to a high enough dose to get optimal effect, both because sometimes the two together mean you don't need a higher dose, but also because this medication can actually offset some of the side effects that some people get with stimulants, such as the feeling too revved up, irritable, anxious, jazzed, that kind of thing. Okay. Side effects, pretty low side effect profile, as we like to say, but it's usually fatigue, sleepiness, dizziness. Technically speaking, we can see low blood pressure, but honestly, we don't really see that very often. Biggest cons are that, like I said, they're less effective as a solo agent. But the biggest downside, honestly, is that for the extended release formulations, they only come in a tablet that cannot be crushed, that has to be swallowed whole. So that's the biggest problem for our folks who may not be able to swallow pills, okay? The other thing that's really interesting about these medicines is they're actually one of our first line medications for tics. So for somebody who maybe already has tics or has tics that are uncovered or exacerbated by their stimulant medication, but their stimulant is working wonders for them, okay, this might be a good adjunct for them, okay? These also come in immediate release formulation, just good old generic clonidine and guanfacine. They last about 8 hours. They do have a tendency to cause more sleepiness though. So how do we use them? We use them for sleep. This can be really helpful for those of us who suffer from the ADHD brain spin at night because our brains won't turn off. The way I've started to describe this to my patients is it's not that the voices go away, it's that the volume gets turned down and they raise their hand and take turns. Okay. And it just kind of helps bring everything down a little bit to help us chill and get to sleep. Now, the other thing that we will sometimes use, so for our kids who can't swallow pills or our adults who can't swallow pills, you can, in theory, crush the immediate release and use that and dose it 2 or 3 times a day. And not everybody has too much sleepiness with these. Some folks absolutely can tolerate that, and it can be used during the day, and they do really well with it. So that is sometimes a way we will use those medications. Other non-stimulant medications. Qelbree is the newest kid on the block, okay? This is the one that's come out the most recently. It is currently approved for kids 18 and under, or under 18, 17 and under. They are expecting their adult approval from the FDA, honestly, any minute. They've been saying April for quite some time. So probably this month or next month, fingers crossed. It is what we call an SNRI, or selective norepinephrine reuptake inhibitor. So what this one does, remember that other neurotransmitter I talked about at the beginning that we've been neglecting ever since? This one increases available norepinephrine in the brain. Okay. What's interesting about this one is the dosing is a little bit different. It's not size or severity based, but it is age based. And they have, they basically start, depending on the age, you start a particular dose and you go up to a particular max dose. And we titrate again, adjust it based on efficacy. This one's interesting too, because unlike things like antidepressants, which can take 4 to 6 weeks to take full effect, This one doesn't take that long, but it's also not as quick as a stimulant, which is like quick on, quick off. This one takes about a week to start being effective, but up to 4 weeks to reach max efficacy. And again, one of the positives are that it's not a controlled substance and that it provides 24-hour coverage. The other thing is their literature suggests that it can be helpful it can be used as a solo agent or an adjunct, and that it can be efficacious for all of the core ADHD symptoms. So whereas like the guanfacine and clonidine don't really help much with focus and attention, but help with the kind of hyperactivity, impulsivity symptoms, the research, or Kelbree's research, suggests that it can be effective for all the core symptoms of ADHD. Side effects, though, do include drowsiness, decreased appetite, tiredness, nausea, vomiting, irritability, trouble sleeping. Other cons include the fact that obviously it's still new. There's no head-to-head data comparing it to stimulant, because that's not how you do trials when you're getting your FDA approval. You compare it to placebo. So the data they have is in comparison to placebo, not in comparison to gold standard stimulant therapy. And like I said, not quite yet approved for adults. Cost, of course, can be highly variable because it is a new medication, although there is a coupon program. This is one that I'll be honest, I haven't used a whole lot because I have a really hard time starting somebody on something that's fairly new when I haven't tried a gold standard treatment, or unless they haven't tolerated gold standard treatment. The other issue is I have tried it in a few patients, and I really only have one patient for whom it's been really effective. The other ones have had to stop it because it wasn't effective for them and they couldn't tolerate the side effects. But again, that is a very small group of patients. So that doesn't mean that it's not a worthwhile medication or not to try it. It's just, I don't have the personal experience to really go, yay, use this one. Okay.
Carolyn,
yes.
I'm going to ask you to, I'm giving you a 5-minute warning.
Gotcha. Okay,
so
Strattera,
have time for questions. We have a lot of questions.
Yeah,
and,
absolutely. So the Strattera, I just want to mention really briefly because this is one that, again, a lot of people are aware of because it's been around for a long time. It is also a selective norepinephrine reuptake inhibitor. And really, I'll skip the details on this. The big point is that most of us who do a lot of work in ADHD are no longer using this medication, or at least not using it very much. It's over time has really shown itself to not be terribly effective, and especially given the potential side effect profile. Now, for sure, if it ain't broke, don't fix it. If you're taking it, if someone you love is taking it and it's working for you, that doesn't mean stop this medication or switch medications. It's just not one that we're usually starting very frequently in people anymore because it just hasn't been shown to be as effective, and especially for the potential side effect profile. Okay. Other ones I just want to mention the names of Wellbutrin, which is an antidepressant, but it's one that primarily affects dopamine, can be helpful and effective for ADHD. Again, down the line, it's also one that might be helpful for somebody who has coexisting depression. And then there's things like the tricyclic antidepressants and some other medications that are further down the line that, again, are primarily helpful if you have somebody who has coexisting depression or anxiety along with their ADHD. Okay, so one of the things I tend to talk about, I'm just going to do this pretty quickly, is kind of how you get started. And the big take home here is simply, I tell people to start with their primary care doctor. If your primary care doctor is comfortable with these medications and comfortable with ADHD, great. You may not have to look any further. Otherwise, they can refer you to the folks in the area, whether it's psychiatry, developmental peds, neurology, or another primary care doctor who's just more comfortable with it. And in general, the main point of these kinds of slides is the fact that medication is part of first-line gold standard therapy, in addition to things like parent behavioral training, classroom interventions. The only age group for which that's not the case is 4 to 6-year-olds. For those folks, we start the other interventions first, and we circle back to medication if those other interventions are not sufficient, because the 4 to 6-year-olds have a higher risk of side effects with the stimulant medications. And if they do need one, we start methylphenidate, not an amphetamine. Okay. Things we take into consideration when we're trying to figure out where to start. The good news is we've got a lot of options, as you saw. The bad news is we have a lot of options. So we take things into consideration like personal history, family history, other medical conditions, other mental health conditions to kind of try to help us narrow the field. But the fact of the matter is we don't really know until we try. And it can take time. It can take trying different medications. It can try different doses of different medications. It can try adding adjunct medications. So I really try to set expectations and encourage people as much as possible to not get too discouraged, and to stick with it. Because when you do find the right medication, it can be an absolute game changer. Again, we start low and titrate up. There's a lot of trial and error. We can titrate these medications pretty quick, the stimulant medications pretty quickly, actually every 3 to 5 days, but I usually tell my patients every week just because it's easier to remember. If you're having side effects though, I tell folks if it's mild and tolerable, you want to stick with it for about 2 weeks because that's how long it can take for side effects to go away. Appetite takes a little longer. After that, pretty much what you see is what you're going to get. But if it's not tolerable, then, you know, I'm not going to make you stay on it kind of thing. I did have a couple myths and misconceptions. We have a couple minutes for me to go through at least a few of these real quick.
We do if you're gonna. So we have some. We have a lot of questions, and the questions are, you know, mostly personal and very specific. So,
so one of the things I'm going to say about that is, for obvious reasons, and licensure reasons, I can't get into really telling any particular individual, right, what to do with their medication regimen. We can kind of talk in general about things or things to kind of ways to talk to your provider. But nothing I say should be taken to, shall we say, replace the advice of your own personal provider. I have to kind of put that out there.
Absolutely.
So cool. So let me touch on a couple of these just real quick, and then we'll get to the questions. So one of the biggest things I do want to hit on, because I did mention that whole issue with diversion of some of the medications, is there's this myth and misconception that ADHD medications cause addiction. And I want to be really clear on this. When these medications are used at appropriate dosages and are monitored by a medical professional, they have an extremely low risk of addiction and, more importantly, or dependence. But more importantly, what the research shows us is that proper and optimal treatment of our ADHD actually significantly decreases risk for substance use, abuse, or dependence. Okay, so it's actually the opposite situation. And I think that's incredibly important. And it's something that oftentimes is a barrier of care to us, because that misconception affects how medical professionals approach us, how pharmacists approach us, how lawmakers approach us, how we approach ourselves, and how we approach these medications. And it's one that I get on a major soapbox about. The other one that really bugs me is when I hear that, well, you know, we shouldn't start medications. We should use that as a last resort. No, nothing else I do in medication as a primary care provider do I wait until somebody's in crisis. I don't wait until a diabetic is in the ICU in diabetic ketoacidosis to start insulin. I don't wait until an asthmatic is on a ventilator in the ICU to start albuterol. Okay. If someone has a diagnosis of ADHD, part of that diagnosis by definition means it is causing problems. Okay. And for most of us, by the time we are outwardly in crisis, it's been going on for a while, right? And we've been compensating for a very long time or masking for a very long time, and it's been at a cost. Okay, there is a cost to not treating our ADHD, just like there's potential side effects to the actual medications. So that's another one that I like to really kind of make sure we're aware of. And then the last but not least, because I think it absolutely has to be said, medication is not failure. There is this massive, I think, misconception and just thought process for so many of us that whether or not we're choosing medication for our children or for ourselves, it means that we've somehow failed. As an adult with ADHD, I'm a physician. I own my own practice. I should be able to find my shoes in the morning. I should be able to get my kids to school on time. My car should be clean. And I should be able to do those basic adult things without medication, right? If you are choosing medication for your children, it's because you failed as a parent, because if you could just parent them differently, if you could just parent them better. And we think this and we believe this for a reason, because these are the messages that we're getting sent, right?
Okay. So, Carolyn, hi. This is great. I'm going to wind you down right now. I know you have to put your kids to bed. And this is a great point that you're making about shame. Most of the questions that we're getting are personal. Andrea, you were going to look at them and see if you could call what, if there's any themes or.
Just thinking, Carolyn, can you maybe speak to the swabbing?
The genetic testing?
Yes. What's your thoughts on that?
Yeah. So that's a question I get a lot. So the pharmacogenetic testing, there's a lot of kind of debate on that. There's certainly folks that will tell you it's bunk, it's worthless, blah, 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 blah. No, there is some value to it, but it's also not a magic bullet by any stretch of the means. And with ADHD medications in particular, actually, it doesn't seem to be as helpful. The data can be a little bit more helpful when it comes to antidepressants and things like that.
Thank you so much.
That's so good to know, yeah.
Somebody asked if you give some tips for dry mouth. Their child has terrible dry mouth.
Yeah, the dry mouth stinks. Actually, speaking of which, honestly, there's not a great tip for that other than just keep them drinking water. If it's enough that it's really bothersome to them, then it may be enough to try a different medication. But that's unfortunately not one that's necessarily going to get, there's actually some side effects that can get better when you go up on the dose. That's not one of them, typically. But yeah, unfortunately, there's not a great one for that other than just staying hydrated.
Somebody's asking, would you ever start with a non-stimulant for a child who displays more emotional dysregulation and aggression rather than the focus as their overarching issue?
Yes, I would. Thank you for that question. Yeah, that is actually one of the scenarios where I would consider starting an alpha adrenergic. Either as a solo agent or I've definitely had some kids for whom starting the alpha adrenergic first then enabled them to tolerate the stimulant and tolerate it better. And in general, I've got this whole, in fact, I'm kind of thinking about the fact that I probably need to write this up because I have a whole cadre of kiddos who have similar symptom sets. They have a lot of emotional dysregulation, irritability, anxiety, explosive behavior. These are the kids who often get labeled emotionally disturbed. Don't get me started on that label. We'll be here all night. Or ODD, another term that needs to be stricken from our lexicon completely. Those kiddos, in general, most of mine who have that kind of symptom set are ADHD and anxiety, and they have done very well on a combination of methylphenidate and guanfacine. And I think it's the combination of the two that's really helpful for them. But yeah, that's exactly the kid that if I were going to start anybody on a non-stimulant first, it would be that kid.
So just wondering, because most of the questions that I see are personal questions, and you just spoke about your feelings about personal questions. Well, so is there anything that you'd like to?
There's like pearls that we can pull from those.
Sure.
So there is a question about, somebody asks, does medication actually help with the executive functioning piece of ADHD? That's a good question.
That is a good question. Yes, but it's often not, like I said, it's often not an end-all be-all in and of itself. Certainly the executive function stuff, we often need to have systems in place. We need to have a bazillion alarms set. We do need to figure out systems that work for us, but I do find that the stimulant medications or medication in general certainly can help us implement those things better. It absolutely can help with organization, can help with initiation and maintenance of strategies, tasks, task completion, those kinds of things. So yeah, I do find that it can help with executive function, but again, oftentimes it's not an end all be all.
Now we have another question here. Do most kids you prescribe for stay on meds through adulthood? What are you seeing about that?
So that is a great question. We have ADHD. We don't stay on our meds. Okay, let's call a spade a spade. We go through phases, right? Sometimes we stop our meds because we want to stop our meds. Sometimes we stop our meds because we forget. Sometimes we stop our meds because we forgot to get our refill, and then we decide we're doing okay. So we stay off of our meds until we realize we're not doing okay, and then we get our meds back, right? And that's the typical pattern I actually see throughout the lifespan, right? And it really just depends on the person. It depends on the extent that their ADHD is interfering in their life. But the other thing that's actually really interesting about that point is the multimodal treatment study, which was this huge study that was done over many, many years, following folks from early childhood into adulthood, and they're still doing it. Initially, we had this concept that we grow out of ADHD, which of course has been debunked. We might get better with our impulsivity, hyperactivity, things like that, but we don't grow out of it. We change, it changes how we are affected. What they're starting to find is part of that came from when they were taking these single data points from folks as adults. And in these single data points and these single moments in time, their ADHD wasn't affecting them as much as it used to, and it wasn't as bad. But if you keep following them and you take enough data points, what they've started to see and actually publish in the research is that it's variable throughout time, how much we, could you say that again? How much it is affecting us. And it's not that the ADHD goes away or necessarily gets better and worse. It's more how it's affecting our lives, right? And so that's kind of been interesting. And I think for any of us who have ADHD as adults and have gone through quite a bit of our lifespan with it, it makes sense. We're like, yeah, pretty much. Like, it wasn't as much of an issue for me when I was a young adult with my own schedule and no kids or husband to manage. It's a lot harder now, right? So
absolutely. And it's 9:15, which
it is 9:15
when we typically end. Look at you, Carolyn, you did a great job. We just kind of pulled it all together. And what you're saying about what you're talking about is women and ADHD and how, the sailing the boat and the windy waters changes when we have little kids and teenagers and husbands, and depending if we're working full-time, part-time. So the environment and the demands of the environment really manifest in ways that make us look or feel more ADHD or less ADHD. Yeah. Okay. So this was great. I'm so delighted that you came and joined us. I really am. And I actually got someone who runs the Suffolk County CHAD chapter said, wouldn't this be wonderful if CHAD National got a talk like this from you and could.
So if you come to the conference in November, no, actually, I'm going to use that as a plug, if you will. I do some talking for CHAD, but in all seriousness, the conference this year is going to be November 17th, 18th, 19th. COVID willing, it will be here in my hometown, Dallas, Texas, and we are doing a hybrid version. So there will be an online option, but I do highly recommend you come in person if you at all can, because it is 3 of the most soul affirming days. It is a place where you can use neurotypical as an insult and go skipping down the hallways and still respect it as a professional. And I am in charge of one of the people in charge of the party, and it's going to be a good one.
All right.
Wow. And hopefully, I mean, obviously I don't know for sure, but hopefully I will be doing 1, if not 2 talks on medication, actually. So I highly recommend the conference. So.
Okay. And somebody might reach out to you from CHAD National about
absolutely
something that we can offer each chapter. either a recording, not that you have to be at each meeting, but a recording. And what we've done in the past is actually had recording like of Tom Brown or of Russell Barkley, and then questions in the middle, and then we stop and people answer questions. So it's for a smaller group, but some of the chapters might find that really helpful. Okay, so thank you all for coming. I hope to see you next month. Next month, we're going to hear about non-medication approaches to ADHD.
I think that's awesome. I think that's great that you have this one now and then that one that that'll be a neat kind of follow-up.
What? Yes, fantastic. So Carolyn, thank you again. Thank you all for being here. And if I only got one request for a future talk, and that was for ADHD and autism. And we will get a speaker for that. And anything else you want, we're here to serve you, our community. All right, so I'm going to say goodnight.
Thanks again.
Carolyn, thanks so much.
Thank you so much for coming. That was wonderful. Really appreciate it.
Thank you.
Thank you. Be well.
Thank you.
Okay,
bye,
so
everyone.
Bye-bye.
So Joni, you want to just close things up? And
sure.
Wait a minute.
Thanks.
Am I just ending the meeting?
Yeah, we're going to end the meeting and we're going to have to stop the recording. How's that? I'll stop.